Get to the panel. Our guests, we're going to call them up one at a time. It'll be about a 12 to 15-minute interview, give or take. We'll see how it goes. And question and answers after that. Maybe we'll wait to do all the questions and answers till later. I'm not sure. We'll see how that goes. But that's kind of basically what the program is going to look like tonight. Okay? Our first guest has been, I'm going in alphabetical order, by the way, so no preference or anything. Our first guest has been with Johns Hopkins Medicine since 2007. Her background includes a long history with international nonprofit startups, and when she returned stateside, the innovation, collaboration, creativity, and compassion for patients that she found within the Johns Hopkins health system fit her personal mission perfectly, and you'll see what I mean in 1 minute. She currently serves as the Executive Director of the Office of Telemedicine at Johns Hopkins Medicine, which provides telemedicine guidance and implementation support to the entire Hopkins organization. Please welcome Rebecca Canino to our event. Is that on?
Hello, hello.
It's on.
Perfect.
Okay.
Hi, everyone.
See what I mean? So I had a chance to actually meet Rebecca via Zoom and the other two panelists, Kerryann and Dr. Fishman. Sorry, last week or 2 weeks ago by Zoom to kind of get to know them a little bit. And everybody's story is interesting and fascinating, but Rebecca's story is truly in that vein. So why don't you I'll let you talk for a minute and then we'll interject, but tell us a little bit about your background and how you came to be here today.
Sure, thanks. So I was kind of raised in the medical missions kind of arena. So my dad was an architect with World Bank, and he took us around the world and designed housing for third world communities, and along the way really picked up a passion for bringing medical care to folks. So we had a medical ship which went through the Caribbean. There was a lot of conflict there at the time, really bringing medical care to folks who needed it. And my mom was really focused on feeding orphans and taking care and empowering women. So we traveled all over the world. I've been to 40 plus countries.
Correct.
And then post-college, did kind of round the world tour on my way to Israel for a bit to visit family and get to know my roots, and got to be privileged enough to work with the Red Crescent. There was a conflict at the time with Armenia and Azerbaijan, still ongoing, unfortunately, and really saw the need for access to medical care, right? Mm-hmm. And I was phoning friends back in Baltimore going, okay, I'm here, this is a situation, what should we be doing, right? And I was privileged to have that access, and I wanted that access for everyone in the whole world.
And also, if we could just take a step back
Sure.
even further, you told me that your grandmother was a member of the first graduating class of women
Yes.
at Johns Hopkins University.
Yes, the
So
first
that's
class. Yep,
amazing.
The first class to allow women. It was
Allow
night
women.
school, and so she graduated with a degree in chemistry and met my grandfather, who was running a lab at Hopkins, and so we have lots of Hopkins roots. And then he went on to be the administrator of cardiology for NIH.
One more fun fact about Rebecca: she is a single mom of 5 siblings.
5 girls.
Who she adopted. And what's the age range?
24, 13, 8, and then twin 5-year-olds.
Twin
I'm very
5-year-olds.
blessed.
So you're not busy or anything?
No, not busy at all.
Okay, wow. How did that come about?
So I knew early on that I wanted to adopt. I come from a family that adopts. I think we have 3 or 4 generations of adopted Fleischmans, and they're throughout the community here. And so I was waiting to be matched, and I got a call. I really wanted just an older teenager because they are very much at risk, one. And so I was waiting to be matched with my child out there, and I got a call that there were 3 little girls whose mother had just passed, and was I interested? And I actually paused, and then I was like, this is the call I've been waiting for my whole life. And so I said yes, and then we found out they had 2 more siblings, and we are now a very happy family.
Well, good. Congratulations. Yeah. And yeah, that's absolutely beautiful.
Yeah, very blessed.
So the innovation that we want to talk about with Rebecca is telemedicine. And it's odd now, but it doesn't seem like an innovation anymore because of the pandemic and, things change and people change and it's just kind of accepted. But I think the story behind what's happening today with telemedicine is really interesting. In fact, you had told me that you had pitched telemedicine to Hopkins in 2007,
Yep.
which is, I'm going to do math real quick, 16 years ago. So what was the reception like? What was the reaction from them at that time?
So at that time, telemedicine has been in Hopkins since the beginning. The grandfather of telemedicine actually came out of Hopkins, and so we have so much innovation. Hospital at home, Dr. Leff, that was innovated here in Baltimore and is now just national. So it was very siloed in specific places. Infectious disease was doing things, dermatology was doing things, but they weren't unified. And at that point, there was absolutely no reimbursement or hope for sustainability for telemedicine. So Hopkins said, that's nice, and looked elsewhere. But it was really great because that proposal, I was a naive 30-something, fresh to corporate healthcare, and I put together a proposal, and Mike Weisfeld, who was the chair of medicine at that point, backed me and said, let's pair you with Redonda Miller, who is now the president of Johns Hopkins, and Charlie Wiener, who's the president of Johns Hopkins International now, and they were both, up and coming and mid-career. Let's see what happens. And so even though they turned us down, 10 years later, I got the call, and I was in my living room, and they said, are you interested in telemedicine? I started dancing. And I was like, yes, I am. And I got hired the next day.
So let's do the timeline there. She started in 2007. 10 years later would have been 2017 with telemedicine. That's before the pandemic.
Yep.
So what motivated Hopkins to give you that call in 2017 to kind of revisit the effort?
Yeah, I think the writing was on the wall, nationally and internationally, that there is just a massive shortage, right, of providers and burnout of providers and a real access issue, that folks who need the care are unable to get the care because of the barriers to care, right? You have to live in the same place where that specialty or subspecialty is. You have to have enough money to get there, right? And be able to take off work, be able to have childcare for your kids, or to bring them across the city 2 hours just to get that care. And so that barrier was so real to Hopkins that they kind of put their money where their mouth was and said, we're going to fund this newfangled telemedicine, and let's see where it goes.
And so from 2017 then to 2020, can you give us an idea as to the number of telemedicine visits, like almost on a timeline? Like what were you doing in 17?
Yep.
What were you doing in 20? What are you doing now?
So in 2017, we did our first visit. It took us a year to build the platform and get someone. We did one visit. In 2018, we had 100 visits, right, for the year, and we were so excited. We had 8 telemedicine champions across the specialties. Addiction medicine, big proponent. Behavioral health, neurology, just such a great use case for telemedicine. You're going to hear from Dr. Fishman about this. So we did 100 visits, 2018, and we celebrated. Like I had a PowerPoint, that I made the fireworks go on. And then we were on track, 2019, to hit 1,000 visits.
Wow.
And we were really excited to hit the mile marker. We were doing, like, if we got 100 in a month, it was like a red banner. It was so exciting. And then the pandemic hit, and I think we did, in 2 days, the entire operations of Johns Hopkins went virtual. So all the ambulatory shut down. We opened up 2 days later, and we're doing 30,000 visits a day. It was crazy.
Oh my God.
Yeah.
That is unbelievable.
Yeah, the learning curve that I don't know ever in history, at least not in my lifetime, where the physician was learning at the same time that the patient was, right? And so you had both sides on this steep learning curve of innovation, right? That should have, I had predicted it'll take us 5 years, right? And we hit our We completed 3 years of goals that I had mapped out for us within the first month, and we were at 5 years within the first year that we broke through every barrier.
Absolutely amazing.
Yep.
So let's talk about some of the issues that revolve around telemedicine. Number one, the insurance situation. I'm sure this is an ongoing event, but what is the current situation with telemedicine as far as it being covered by most insurances?
Yeah, so even before the pandemic, commercial payers had recognized that this was a cost savings and something that their members would benefit from. So they were covering video visits. But Medicare, right, our national payer, it's in the Social Securities Act of like 1972 that a visit by technology cannot replace an in-person visit. And so Medicare took this to mean that you couldn't do a visit in your home. So they were trying to do everything they could within their power to grow telemedicine. And so they said, if you're in a health department, you can do it health department to department, hospital to hospital, right? So they were very narrow use cases. And when you're someone like Hopkins, that more than 50% of our patients are funded by a national payer via, Medicare or Medicaid, it's not sustainable for a provider to say, I'll see you this way and you this way, right? And the inequity of that, right? It's antithetical to who we are. So with the pandemic came Medicare saying, you can be seen in your home. And we saw this tremendous uptake. And what's really interesting, if you look at the data over the pandemic, over like the big 2 years of it, the overall visits were the same across the health system, right? We did the same amount of ambulatory visits that we did in person, but folks with Medicare and Medicaid utilized the services more than the commercial payers, more than folks that were commercially covered, and that was because the barrier had gone away and they could access care. And so it is vitally important. We do so much legislative influence, right? This is where we want to spend our political capital, is making sure that that access doesn't go away. And so you are seeing extension after extension, right, after the PHE, that, okay, you can do it. So right now, almost all of telemedicine is covered through December 31st, 2024. And the reason for that date is so that it'll give Congress enough time to act, so that Medicare can say for their fee schedule, calendar year 26, this will be covered. And so we're really working hand in glove with CMS Innovations, lots of partners like the AMA, the ATA, Center for Connected Health, Alliance for Care. There's so many people banded together to make sure that access stays. And that's at a city level to make sure the infrastructure is there so that everyone can access telemedicine, so they have the data plans to cover it, right? And then it's at the state level for what's allowable for Maryland, and then at the national level for overall coverage.
You're very passionate about disparities in medical coverage, in medicine. We're talking about racial disparities, perhaps economic disparities, even to the elderly as opposed to the young. So talk a little bit about what can be done and what active steps are being taken to break down those disparities and kind of equal it out.
Yeah, it's the age disparity and discrimination is a very real thing, and it starts with a lot of assumptions that our older generations won't be able to access the technology, and that is simply not true. This is the language that they use to speak to their loved ones, right? This is how they communicate. This is how people of all ages date and fall in love. Like the virtual, that access that we have to each other's lives and to each other's homes is just so very real to both the generations coming up, all the way up through, our boomers and our older generation, that this is how we're getting access. And when we look at the kind of access we can have into an older person's home using telemedicine, we're seeing people at their baseline. We're seeing them as they function in their own home to be able to help them. We're seeing them holding their pets with their blood pressure way down versus, lost, having to park in the city, and all that blood pressure coming up and not being able to clearly articulate how they're feeling based on all these other factors of just getting to the doctor versus being able to see them in their own home.
What do you think's next? Like, can you see a next step, another barrier to break, perhaps?
So I think it's going to be sustainable in the next 2 years, right? And with AI coming on board and all these Internet of Things, right? And so my father just passed away from Alzheimer's this past year. I'm very passionate. I can't wait to hear what Dr. Fishman is going to say. But the access to telemedicine for hospice and making sure that he was comfortable and that our family around the world could be with him all through those stages, right? I mean, thank God for places like this that will care for you through those stages, but so many of us are doing that at home and being able to have safety at home with all the new smart devices that we have. I can tell we have sensors that we'll put on the chair, the bed, and the refrigerator, and I'll know maybe if you are sleeping in your chair overnight rather than getting in bed because it's easier for you to breathe. Right? It's an indicator right there that the clinician can be like, okay, this is something to follow up. I know if you've taken your medicine, if you've opened the fridge, if you're eating, right? If you're taking in your fluids with the little smart rings around your water bottle, how often you're using your inhaler, you know, all these things.
That's amazing.
Yeah, that we're able to track passively and take care of someone and to be able to intervene and keep them well. And you're going to hear with ataxia some of those ways to do that, but that is, we want to keep you home, we want to keep you well, and we want to take care of you with your loved ones.
Well, we really appreciate what you do, and just want to thank you so much for joining us today.
It's been a privilege. Thank you, everyone.
That is Rebecca Canino, Executive Director of Telemedicine at Johns Hopkins Medicine. Thank you. Okay. Boy, Dr. Fishman, you're going to have a tough act to follow here. All right. Our next guest is Dr. Fishman. He's a native New Yorker. But before we hold that against him, you should know that he's been in Baltimore now for 40 years. So he's an honorary member of our tribe, and we don't need to ask him where he went to high school. Our guest is a neurologist at the University of Maryland Medical Center, where he specializes in neurodegenerative diseases, including Parkinson's and Alzheimer's. He established the University of Maryland Medical Center's program for neurotoxin treatment of movement disorders and is a co-founder of Deep Brain Stimulation focused ultrasound surgery and Alzheimer's disease programs. And he's also a professor of neurology at the University of Maryland School of Medicine. Please welcome Dr. Paul Fishman. How are you? Your mic is good?
I think so.
Okay.
Okay.
So, again, we had a chance to talk last week or 2 weeks ago, and you described yourself, his words, not mine, as a science nerd. Tell us when that started for you, at what age approximately?
Well, it's probably as young as I can remember. The term actually didn't exist at that time. But I was always curious about how biologic systems worked. And it was kind of unusual because both my wife and I are from engineering families. So they're interested in how things work, but not so great with people, with animals. In our family, the definition of a physician is somebody who doesn't have enough mathematical skills to be an engineer. That's what we were kind of up against. But and it's really kind of funny. It's come full circle that I've been interested in basically why the human brain ages, why we lose brain cells and we don't replace them, why these diseases like Alzheimer's, Parkinson's, ALS even exist. I come from a background of looking at a wide variety of animals, and in nature, you see a lot of regeneration. You know, salamanders lose a limb, they grow a new limb. There are certain animals like fish, during parts of their lifetime, they'll grow another part of their brain. And so I was always interested in why, after injury, after stroke, when these diseases, why do we lose brain but we can't easily replace it?
Right.
And there's been a huge knowledge base in my career, understanding the biology of this. But it's been incredibly frustrating that none of these diseases have anything close to a cure, where we've taken that knowledge and we're still waiting for stem cells, we're still waiting for gene therapy to really turn the clock back on these diseases.
What are we waiting for exactly?
Well, let me hold that one to the end.
Okay.
Because there are a lot of ideas, because what happens is we look at cells, we look at animal models of diseases, and a lot of these, we hear about in the newspaper almost every week that there's some advance, but the likelihood that all these things that look promising in cells, they just haven't worked when we actually apply them to people. So there's enormous controversy in the whole field. I have my own ideas, I'll say for the end, about why that's true, why we can't translate that basic knowledge into that.
Okay.
So I've
yeah.
lapsed back to my engineering roots and technology, which has made some real inroads. And actually having technology, and especially rare technology, telemedicine has been an important arm where we have devices that there only be a handful of them in the country. So how do people know about them? How do people decide whether or not they want to physically travel the thousands of miles to Baltimore for a procedure? Telemedicine is the heart and soul of making that connection.
And one of the innovations that we talked about, and I should mention that you are the longest serving member, if I'm not mistaken, in your department at the University of Maryland since 1983. The old saying is that with experience comes wisdom. So we're hoping that after 40 years you can deliver some of that wisdom to us tonight. Perhaps, we'll see. But my question was going to be, you've done extensive research and work with ultrasound in terms of Parkinson's and Alzheimer's, et cetera, in your career. Tell us a little bit about that. And the reason why I ask is because when I think about ultrasound, I naturally think about, a woman who's pregnant going in for an ultrasound to, make sure everything is okay with her baby. But this is a different application. And just talk a little bit about it.
Well, using ultrasound to generate images, diagnostic ultrasound to look at a pregnancy, to look for a cyst, and there's a good 50 years of, and actually not far down the road was Roger Saunders, who was one of the major, from Hopkins, one of the major OBGYN ultrasounds in the world, but only over the last 10 years has really there been development of what we call therapeutic ultrasound, using ultrasound to actually do therapies. Now, outside of the brain, it's fairly straightforward. It's been used for tumors. You concentrate that sound energy, and when that hits tissue, you can heat it up, and you can coagulate and destroy a tumor outside the body with ultrasound. Now, I've been working with what used to be a small Israeli company and now pretty large Israeli company out of Haifa. A bunch of engineers out of the Technion decided they would take on an engineering task that on the surface seemed impossible, which is to deliver ultrasound through the skull to a target in the brain. To actually, it was first, and we're looking at it in tumors, but to do lesional surgery in the brain where you actually make a lesion without ever opening the skull. Now, there's been surgery for Parkinson's and related conditions for 50, 60 years. And it came out of another New Yorker, a guy named Irving Cooper, who almost accidentally discovered that if he destroyed very specific areas in the brain, and I emphasize the patients in general, having part of your brain destroyed is a very bad idea. But
I can imagine.
Yeah, but in a very targeted area, you can improve symptoms. You can restore balance. If there's one area that's underactive, another area becomes overactive, and the principle is if you destroy that overactive area, you can compensate and restore balance. So it's been around for a long period of time, and the more recent technology, a real engineering advance, was deep brain stimulation surgery. And so in that situation, instead of actually making a lesion, destroying a piece of brain, you actually took pacemaker technology, which I kind of brought along with me. You can probably pass it around as long as I give it back. But this is basically like a pacemaker, but it's implanted just like a pacemaker in the chest. This wire, instead of going into the heart, will go into a very specific brain target. And most of the time it's done awake, so we can be ensured that it's exactly what the patient experiences tells us in a lot of ways where the target is.
How often is this done? I mean, is this regularly done?
Yeah, it's been FDA approved for 20-something years.
Oh.
About 300,000 patients have undergone this type of procedure worldwide.
Why wouldn't everybody undergo that?
Because of the fact that it still has to be implanted into brain. And every surgical consent form that you ever see, there are only 3 important words in it: bleeding, infection, and death. Okay, and so when you have traditional surgery, there's always a risk of bleeding, there's always a risk of infection, and I don't think you have to be a neurologist to think that the worst place you can have bleeding or infection is in your brain. And so that's the major complication when you do this. And that's why this Insightec, this Israeli company, said, gee, let's take a step back. We can destroy a small spot of brain with sonic energy, but we can do it without ever implanting a device, without ever opening the skull. And you don't do that, there's no possibility of bleeding or infection.
Correct. Fascinating. Let me ask you about Parkinson's. You made a very interesting comment when we interviewed that Parkinson's potentially could be qualified as a quasi-Jewish disease. Can you explain that a little bit?
Well, it's interesting that the overall prevalence of Parkinson's is probably similar in Jews and non-Jews. But if you have Parkinson's disease and you're Jewish, there's a very high likelihood that it's inherited. The 2 most prevalent genes that cause Parkinson's disease, both of them have their highest prevalence in Ashkenazic Jews.
Is there, any reason for that? Is that a genetic thing?
Well,
environmental?
Again, probably it may be some degree of selection bias of the whole way. There's an old theory that relates to actually engineering and mathematical skills among Jews, and the fact that in the Middle Ages, Jews were excluded from the major occupations, farming, because you couldn't own land, but Jews were permitted in an occupation that was forbidden to Christians: handling money and banking.
Wow.
And at the time, even simple mathematical calculations were incredibly difficult because they were done with Roman numerals. And if you ever try to do division with Roman numerals, that's not fun.
Or regular numerals.
Right, with that. And so some of these diseases are linked to those skills. We think.
That is really fascinating. I want to get back a final question for Dr. Fishman to kind of peel back from where we were before.
Sure.
You had mentioned like every once in a while, or maybe even more than once in a while, you hear about a breakthrough in stem cell or something, et cetera, but we never seem to be able to come up with the answer as to your original question of why humans are not able to regenerate brain cells, limbs, et cetera. What is preventing us from the breakthrough that we would be able to do that?
Well, evolution didn't anticipate us being as old as we are. Evolution is all about preserving the species, not the individual. And so when you have diseases that are occurring in mostly people well beyond their childbearing years, things you gain and you lose. I think what's well known in terms of long-lasting regenerability, the simplest thing is, why can't we not regrow a limb? A lot of animals regrow limbs, they regrow tails, limbs, but why not? And evolutionary biologists have this idea you gain something and you lose something. All those animals have lower pressure heart systems. So in mammals, we have a much higher metabolic rate than lower animals. Our hearts pump faster. we have a much more robust circulatory system to supply that metabolic need, including our brain. The downside of that? If you have an injury, a wound, your likelihood that you're going to bleed to death goes up. Instead of oozing, that arterial pumper. And so the priority in evolution was not the long game, regrowing a limb, keeping you from bleeding to death over the next 10 minutes. And so the idea of a robust coagulation system, a robust scarring system to tack things down became a bigger priority than regenerative ability. That's kind of pie in the sky that you might need 10 or 20 years ago. And so that's the way some of evolutionary biologists look at it. And when we talk about stem cells, yes, they're embryonic, they do great things in a dish, but to cure human disease, you're putting them in an older brain that they don't have the signals to tell them where to go, what to do. Those genes, many genes that guide them have been shut down. So it's a much harder, having a cell just sit alive, unconnected, or even worse, connected to the wrong other brain cells, is not going to cure anybody's disease.
Thank you very much. Dr. Paul Fishman from the University of Maryland Medical Systems. Thank you. Our final guest is a certified registered family nurse practitioner and a master certified nutrition and wellness coach. With her wealth of experience, she is dedicated to helping individuals achieve optimal well-being and live a happy, healthy life. She provides personalized recommendations and proven strategies to motivate her clients toward reaching their weight loss and wellness goals. Please welcome the founder of Evexia Weight Loss and Wellness Clinic, Kerryann Gross. How are you?
Great, Gary. How are you?
I'm good, thank you. Welcome.
Thank you.
So, your story, everybody's story is interesting. Born in Jamaica, migrated to the U.S. as a toddler, schooled and trained in Texas. How did you get to Baltimore?
So, my ex-husband was in the 2003 war in Iraq. While we were there, I was with a lot of military wives who were very emotional. I
can imagine.
Nurse at that time, and I wasn't about the emotions, and, I'm all about, let's get better, let's, motivate them to get better, but I couldn't do any more of the military wife thing, so I looked for a job, and I was trauma trained in Texas, so it was at Brackenridge Hospital in Scott and White, Baylor, and so I looked for best trauma centers, wherever.
Here you go, University of Maryland.
University of Maryland Shock Trauma Center. So I was there. I actually got hired at VCU, Virginia Commonwealth University. University of Maryland was paying me less. However, they had so much data on them, and I said, why not be amongst the best?
Well, absolutely,
So,
and I think it's a
took
great
me to
move,
University of
absolutely.
Maryland for 13 years.
And so another interesting, so your journey didn't end there, right? You were a shock trauma nurse at the University of Maryland Shock Trauma Center, but now you're into wellness and nutrition. So
Yes.
that's quite a journey.
Yes.
What happened? Why from shock trauma to this?
So in 2013, I was diagnosed with ovarian cancer. So that was a big hit to who I was, healthy, busy. My family, no one has cancer. My mother's sitting right there. She's almost 70, and she doesn't take a medication besides vitamins. So why did I come and have ovarian cancer? No one in the family has that. And so with the, questions and being interested and just fascinated with what's going on with my body, after seeing about 4 doctors, none of which could diagnose me with what was going on. Why
Really?
did I
Wow.
cease menses? And when I was diagnosed, I started looking into reasons for ovarian cancer. How does this come about? And there was lots of studies from Hopkins, from UMass, from Harvard Medical, even in European studies that shows that there's, over 50 different cancer species, none of which are familial, hereditary, and most of which are environmental causes. I delved more into nutrition, what's going on in our environment, how can we get better? And I was just fascinated with how the environment is affecting us as a species.
So let's talk about that. So it's so the environment. And the reason why I think that's fascinating is because when most people think about, and maybe this is old thinking, about weight loss or weight gain or obesity, et cetera, that whole issue, it's, well, you must eat too much, or you must not exercise enough, or, it's like something that you did, right? But you're here to tell us that maybe that's true, okay? But there are other factors, perhaps even beyond your control, that you may not even be aware of in your environment that could be helping this situation or hurting this situation.
Absolutely, Gary. So, obesity is not a math problem. It's not calorie in, workout, you get better. There are so many different factors. You can eat 2,000 calories. I can eat 2,000 calories. I'll gain 10 pounds, and you'll actually probably lose. And so obesity is about environmental factors. There's obesogens in our environment. There's things.
Can you talk about that? What is an obesogen?
Obesogen is something in the environment that makes you stimulate hormones that increases your adiposity, which is your fat pockets, like this. So these are things like parabens and makeup. These are plastic, absolutely. Plastic is one of the biggest ones. There's the Teflon in our nonstick pans that we have. There's, lots in our foods.
How do you get knowledgeable about these things?
So, that's a good question. I think there's a good thing we have this information world now. There's research, but I think as a medical practitioner, and medicine needs to just catch up with, hey, let's take care of hormones. Let's take care of what we are lacking in our minerals, vitamins, what we can optimize on, not just normalizing this range, but we need who wants to live in, okay, you're normal between 1 and 10, let's do nothing about it. Don't we want to live closer to 10 as much as possible? So I think when our medical practitioners become more aware, we can take that to our patients. Unfortunately, there's so much with insurance-driven and pharmaceutical-driven and the reimbursement. So it's not all just black and white. We have to really get more people involved in what's in our environment and get the educational aspect of it.
So when a person comes to see you, let's say they are worried about their weight, okay? How do you begin the process of assessing their situation before you can make a recommendation?
Sure. So my assessment doesn't just come with, do you meet this BMI? It doesn't do that. I want to know what you're doing in your environment. What does your environment look like? Do you take your lunch? Do you sleep well? How much are you hydrated? Is your job stressful? So I take all the pillars involved, your mental health, that's a big aspect. I mean, obesity is so much neurobehavioral that people don't understand. Like, that is a big aspect of it, understanding how do you handle stress? What is your stress level at work with your environment? Your kids, do you have 5 kids? Things like that. So I really want to know about your whole life from the time you wake up to the time you go to sleep.
So, and is food intake and exercise a part of that?
Absolutely,
Okay.
absolutely.
Right. So it's not only environmental, it's
No.
your habits.
Absolutely, your
Gotcha.
health habits.
And now all of a sudden medications are in the news that aren't even necessarily for weight loss, but they are, like for diabetes, for instance, we're talking about Ozempic, Wegovy, Mounjaro, I believe, that are for other maladies that may affect you. But I guess a side, we'll call it benefit maybe, is that people are losing weight. What's your position on these medications?
Right, so I think there's a lot of political part of what people don't understand. The GLP-1s, the GIPs, semaglutide and tirzepatide, those are the generic names for Ozempic, Wegovy, and Mounjaro. I think what has happened is people thought of it as, okay, this is a diabetic drug. Why is this person using this? And what has happened is there's a history of pharmaceuticals that came about because of a, in the Caribbean we say buck up, but what basically it means is, it happened because we're not sure. We tested it as one thing. There's like warfarin that was tested on horses that we realized that these horses were bleeding out. And so what happened is, hey, we can use this as an anticoagulant for things like atrial fibrillation or blood clots in the brain or coagulopathies. We can actually use it for that. So semaglutide, the GLP-1, GIP medications have been around 14, 15 years, originally used in diabetics, but what happened was we realized, hey, these diabetics are getting better because they're losing weight. What's happening on the cellular level? And so it was started that way, and what happens is science said, hey, let's try it for weight loss, and it's worked tremendously. And I see patients that have made complete turnaround of their lifestyle. I mean, getting rid of habits that they never thought they would get rid of. I have just recently today, I have a patient that said, when I met you, my hemoglobin A1C was 11, and today it's 5.6, which is in a normal range. So just amazing results from these GLP-1s and GIP medications.
But are you concerned about potential side effects? And if so, what are they?
So side effects that I'm seeing in my clinic, and again, I have the luxury of not having to see 36 to 40 patients a day, so I can text patients back right away. So side effects that are most common are nausea, vomiting, constipation. Some patients who are dehydrated, they experience sometimes headaches, fatigue. Those are most common side effects. I haven't seen any extreme side effects as of yet. The reality of it is you can take a person and put them on any medication out here for any number of disease processes, and you're going to have some GI issues.
What about access to these medications and expense?
Right. Yeah, that's a huge problem. The access to medication, right now, if you have a type 2 diabetes diagnosis, you're more likely going to get covered. However, there are some people that do extremely well with these medications, like those patients with PCOS, insulin resistance, that is used off-label, that they need the medication for. So, I try to be as cost-effective as possible. I do not take insurance. But I do think that our industry, the innovation part is science needs to catch up with wellness.
Absolutely. Final question for you. We were, again, talking beforehand. As far as the environmental factors that may be affecting someone's wellness and innovations, you're talking about endocrine disruptors.
Yes.
Can you explain what that is
Yes.
and how innovative that is?
So the endocrine disruptors, as I talked about before, were the obesogens. But the other thing is we're not understanding the malnutrient part. So it's not malnutrient, like you're not getting enough food, but are your minerals optimized? Are your nutrients optimized? Vitamin D is huge for inflammatory, just fighting against these cytokines. Our perimenopausal and menopausal women, that is like the target that needs to be understood more and more and more. And what's happening is these endocrine disruptors, basically hormone disruptors in our environment, just has perimenopausal and menopausal women just going haywire. And so we're gaining weight out. We're not able to metabolize medications, foods like we should. We have brain fog. We have, insomnia, things like that. And so endocrine disruptors basically interrupting our hormones.
So here's a final thought for you. I'm going to quote from your bio for a second. Leveraging your years of medical expertise, Kerryann ensures that the path to wellness is founded on sound principles and steadfast beliefs. What are those sound principles and steadfast beliefs?
So my sound principle and steadfast belief is that getting to the root cause of disease is where we should start. It shouldn't start with, you have high blood pressure, here's a medication. Why do you have high blood pressure? Is there something else going on in your environment? Why do you have diabetes? Is this purely hereditary? What can we do about it? Understanding the root cause is where I start.
I love it. Thank you so much. Kerryann Gross.
Thank you.